Shall I begin, sir?
Yes.
Okay. Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as a digital partner for this event, and the focus of today's session is USGRA-Chestwall Blocks. And now I would like to invite Dr.AL.Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions including governing council member, president, and state secretary of ISA Tamil Nadu State Branch. To proceed with the session, over to you, sir.
Thank you, Clernet. At the outset, I request our Puthukkottai City Branch President, Dr. Munian, to deliver his address.
Good evening, all. On behalf of ISA Puthukkottai City Branch, welcome all faculties, our moderator, our academic chairman, and delegates for the online webinar, which is a 24th episode of second edition of Puthukkottai Bhudhan. Today, we are going to talk about the ultrasound guided nerve block. Already, we have completed ultrasound guided nerve block for upper limb and lower limb. Today, we are going to talk about the ultrasound guided nerve block for chest wall. Ultrasound guided chest wall block we revolutionized pain management for various thoracic procedures. Before going to about block, we have to know about the benefits of the ultrasound guided nerve block, which is a simple to perform effective pain management for thoracic epidural and paravertebral block, which is an alternative method for thoracic epidural. It's also reduced opioid consumption and improved patient's satisfaction, which is applicable for various clinical scenarios like including post-operative pain management and chronic pain relief. Before going to the chest wall block, we have to know about the chest wall innervations. On the chest wall is innervated by the intercostal nerves, which is T1 to T6, which supplies the sensory innervation to the skin and muscles of the chest wall. And second one is the pectoral nerve, which is medial and lateral pectoral nerves, which innervates the pectoralis major and minor muscles. The another one is a long thoracic nerve, which supplies the serratus anterior. And the posterior chest wall is innervated by the thoracic nerves T1 to T12, which is provides sensory supply to the skin and muscles of the back. And intercostal nerve T1 to T6 also innervates the posterior chest wall. The another nerve is the thoracodorsal nerve, which supplies the latissimus of the dorsal muscles, and the supraclavicular nerve, which supplies the upper chest wall and the shoulder joint. What are the types of block? It is anterior chest wall blocks, which is one is the text 1 blocks. Here we have to inject the local drugs between the pectoralis major and minor muscles, targeting the pectoral nerves. Text 2 blocks, which blocks the pectoral nerves, intercostal nerves, and long thoracic nerves. The another one is posterior chest wall block. It is nothing but called erector spinae block. Targets the ventral rami in the paravertebral and intercostal space, providing analgesia for thoracic and abdominal procedures. Intercostal nerves used for diagnosing and treating the conditions like rib fractures, thoracic surgery, and chronic pain management. We have to understand the ultrasound techniques. High frequency linear probes is used for superficial structures, and low frequency curvilinear used for deeper structures. So ultrasound technique is a real-time ultrasound guidance, ensures a precise needle placement and local anesthetic volume spread. What are the clinical applications? Post-operative pain management for thoracic surgery, breast surgery, and abdominal procedures. Chronic pain relief for conditions like rib fractures, thoracic trauma, and cancer pain. Diagnostic and therapeutic procedures like intercostal neuralgia. Today, our speakers are interested to share their experience with all of us. Let's listen the online webinar. So over to you, sir. Thank you, sir.
Thank you, Mr. President. Now I request Secretary Dr. Kannan to offer his secretary report.
Good evening all. I am Dr. Kannan, Secretary ISA Puthukkottai City Branch. Successfully, we are conducting 24th webinar of second edition of Puthukkottai Bhudhan today. Today, our topic is ultrasound guided regional anesthesia chest wall blocks. I welcome all our eminent speakers to the webinar. Last week, 25th June, we have conducted successfully 23rd webinar. Last webinar topic was ultrasound guided regional anesthesia lower limb. We have divided the topic into three subtopics. First one is lower limb pain generator. Second one is ultrasound guided regional anesthesia for hip and knee replacement. Third one is ultrasound guided sciatic nerve blocks. Our moderator was Dr. Murali Tondabavi. He is senior consultant in Apollo Hospitals, Bangalore. First subtopic, lower limb pain generator, was done by Dr. Gautam Reddy, Apollo Specialty Hospital, Bangalore. Second subtopic, hip and knee replacement, was done by Dr. Amrita Rath, Associate Professor, IMS, Banaras Hindu University, Varanasi. Third subtopic, ultrasound guided sciatic nerve block, was done by Dr. Archana Areti, Associate Professor, KMCH Institute of Health and Research Institute, Coimbatore. Last week, around 855 delegates have attended our webinar. And one more thing, an important one, our academic chairman, Dr. A.L.Meenakshi sir, is going to contest in ISA National President-elect 2025. You all know, he is well-known academic person and social service. Kindly elect our academic chairman as President-elect 2025 National. Thank you all.
Thank you, Dr. Kannan, Secretary. Now it is my duty to introduce the faculty to the delegates. So we are happy that we are going ahead with the 24 and we are just nearing halfway, which is the 26. And today we are happy that all are from Tamil Nadu, our parent state branch. So this is only the second time out of 24 episodes. This is only the second time that we are having Tamil Nadu speakers, but previous episode, the moderator was from Karnataka. But now even the moderator was from Tamil Nadu. So in that we are happy that our state, the entire state team is hosting the first time a webinar in this 24 webinar series. And we thank Dr. Narmatha Yangtse for accepted our request and arranging two faculty from Coimbatore Medical College. So the youngest faculty now will be Dr. Anita, who is the postgraduate in Coimbatore Medical College, final year postgraduate, and she did her MBBS in Tagore Medical College. And she is a service candidate. She has worked in PSC for 5 years and joined anesthesia. And she's interested in sports also. She likes to play badminton, meaning shuttlecock or ball badminton, I don't know. So she's interested in playing badminton. And the interesting fact is her husband is also an anesthesiologist. So he is by name Ram Kumar. And naturally, what I expected during post-graduation, they would have mutually anesthetized each other, but it had not happened. So she was only MBBS graduate. Now only she has joined anesthesia. So it means Ram Kumar has anesthetized her to take up anesthesiology. And she has preferred Coimbatore Medical College. So we wish her all the best in future also to be a successful anesthesiologist under the great leader, Dr. Narmatha. The second speaker is going to be Dr. Mytili. She's an assistant professor and she did her PG in Stanley Medical College. She has worked as an assistant professor in Salem and got transferred to Coimbatore Medical College. She has cleared her Diploma of National Board in 2017. So in addition to her academic interests, she is interested in trekking. I don't know where she is trekking in Coimbatore or Vellingiri, or she will be trekking straight to Ooty. I don't know what she is going to do. And in addition to that, she is interested in singing and gardening. So we have to see her house whether there is a real garden or not, or it is simply namesake, it is gardening. But Dr. Kingsley is a good interested person in gardening. So we are supposed to say Kingsley is a good gardener, but he's a good anesthesiologist. But we are happy to have Dr. Mytili as the person who is interested in gardening. So the third faculty is going to be Dr. Narmatha Yangtse. Many people don't know what is Yangtse. Yangtse is a river actually. So she had that river name in her name, and she is associate professor of Coimbatore Medical College, and she is interested in regional analgesia. She has done her post graduation in Tanjavur Medical College. Dr. Kingsley has also done his post graduation in Tanjavur Medical College. And luckily, when these people were doing their post graduation, I happened to work in Tanjavur. It is other way stating, I cannot say that they are my students because they are bright. In spite of associated with me, somehow they have become intelligent without my influence. So I should congratulate both of them. And she is a faculty in ISACON. She is a workshop faculty, ultrasound guided nerve block workshop faculty in GARG, that is Ganga Anesthesia Conference. And she was a faculty in Puthukkottai Bhudhan also. Now on webinar she has come. She has participated as a faculty physically in Puthukkottai CME, ultrasound guided nerve block workshop held on June 14th. And she, in addition to her academic interests, she is interested in chess. So she is a chess champion in her house. They will play within the three, and she has become a champion. And she is interested in many social service activities. She is a dog lover. So that is a pet animal. She is interested in that. So naturally, when she is having affectionate approach to the animals, she is affectionate to her postgraduates and anesthesiologists also. Many postgraduates have sent congratulatory letters to her. So we wish her all the best in the future years to come. And again, to moderate these people from Coimbatore, we called Dr. Selvakumar Kingslin from Kanyakumari. So Dr. Kingslin is a chief anesthesiologist. She is a retired chief anesthesiologist from Kanyakumari Medical College. But even after retirement, people like me, they will spend the time in a useless way. But Kingsley opted in a useful way. He has become the chief anesthetist of Deravium Hospital, which is an orthopedic hospital. So in and out, he is performing blocks. We have finished upper limb and lower limb blocks in our webinar. And he right and left, he is doing upper and lower limb blocks. That is right upper limb, left upper limb, right lower limb, left lower limb. So right and left he is blocking. And the chest wall blocks, he performed rarely, but he is interested in doing that. So he has inoculated some interest in that chest wall blocks because of fractured ribs he frequently encounter in his patients. So he has dominated the whole Kanyakumari by this regional anesthesia approach. Actually, he has arranged Dr. Janil McLeon for Puthukkottai Bhudhan webinar. So he is interested in everything. And more than that, as I said, he is interested in gardening. Like he knows everything about the plant and the plant kingdom. And you have to see to believe, you have to visit his house, how he is maintaining a garden. Dr. Mytili can do that if we go to Kanyakumari. And whenever we go to Kanyakumari, he receives us and he takes us everywhere. Whatever the temple we say, he will take us. Even though he is not specifically interested, he is interested in friendship. So he used to take us everywhere. Till Kerala, he will take us. So that is an advantage. He is known for his great hospitality. His spouse is also known for the hospitality, and his children are in United States. So he frequently goes there also to import techniques here. And we are happy to have Dr. Kingsley as our moderator today. Now it is over to Kingsley. You can proceed.
Good evening, everyone. Thank you, Dr. Munian, Dr. Kannan, and Dr. Hema of Puthukkottai ISA for inviting me to moderate this session. Thank you, Meenakshi sir, for your kind words. I am proudly say I was a student of Dr. Meenakshi Sundaram. I did my MD completed my MD in 2001 in Tanjore Medical College. And still now I am having close association with Meenakshi Sundaram sir. I have personal experience about his capability as a good administrator, good teacher, and a good poet, Tamil poet. He is so fond of Kannadasan. He has written so many books, and he recently has written poet on Tirukkural also. I have most of his books. I had a wonderful time in Tanjavur, and whenever we used to come, when he come to Nagarkoil, and we used to go together, and we had nice times. And he's after completing his first version 1, he is now doing the version 2 of Puthukkottai Bhudhan. I could feel how difficult it will be to organize such a program every week, but he took pain to conduct the program, and he has very large viewership every time. It's viewed by more than 600, 700 people, and he is very particular in bringing very youngsters. There are so many people who are not famous, but there are so many skillful people in rural area, government institution, private institution, and he is very particular in bringing them up. And having Dr. Meenakshi Sundaram as a national president, he will rejuvenate our national ISA body, and he will bring more youngsters and infuse new blood into the stream. And I wish him all success in the future elections, sir. And coming to the today topic, this is Chestwall block, and Dr. Munian described something very few. And Chestwall block, I did do very infrequently, very little I knowledge about that. I do blocks for fracture mainly, and some pain relief cases, epidural and the serratus anterior block. But after I was given topic, I for 1 week I was with this topic, and really it's very good. And in the future, I will try to do almost all the blocks. It's really very interesting. In brief, the paravertebral block and thoracic epidural are the gold standard, but they are difficult to perform, and they are associated with complication. Difficult to perform means it's given in books and it's in almost all articles. But I have attended many workshops by Dr. Shiva Shanmugam, and we can watch Dr. Shiva Shanmugam and his assistant Aarti. They were doing it like just IV cannulation. Dr. Shiva Shanmugam used to do multiple injection from T2 to T6 for breast surgery. Within few minutes, he will finish almost all the 5 spaces. But everyone cannot be Dr. Shiva Shanmugam, but it will be a difficult one. Because of the difficulties and introduction of ultrasound, so many chest wall blocks evolved. There are so many, there's innumerable blocks, but they are broadly classified into anterior block and posterior block. And Dr. Munian mentioned about that. And now, the knowing the anatomy is very essential for performing the block and to select a particular technique for a particular procedure. And hope we'll have a very good time for another next 1 hour. And I'll hand over to the first speaker, Dr. Anita, for chest wall innervation.
With the permission of the moderator, I want to say this time, this webinar invitation was given to the entire India by email. You can check your mail. Yesterday, we have informed about this webinar to the entire members of ISA National. So in that way, it is having a separate credit.
Thanks.
Shall I start, sir?
Yes, yes.
Good evening, everyone. I, Dr. M. Anita, final year postgraduate, Department of Anesthesiology from Coimbatore Medical College. I wholeheartedly thank ISA Puthukkottai Dr.AL.M. sir for the great opportunity and warm welcome. Here I am today to present about innervation of chest wall. The 12 pairs of thoracic nerves originating from the spinal cord entering the intercostal space as intercostal nerves supply thoracic wall, as thoraco-abdominal nerves supply thoracic and abdominal wall, and the T12 subcostal nerves supplies abdominal wall. The thoracic spinal nerves T1 to T12 give rise to intercostal nerves can be classified into typical and atypical based on their course and distribution. The typical thoracic nerves are T3 to T6. They are confined to intercostal spaces, run in the costal groove, innervate intercostal muscle, parietal pleura, skin of the thoracic wall. These nerves follow the classic pattern of intercostal nerves. Hence, it is called typical. The atypical thoracic nerves are T1, T2, T7 to T11 and the T12 nerve. The T1 is atypical because the major part joins the brachial plexus and supplies hand muscles and skin of the medial arm. The T2 give rise to intercostobrachial nerve, supplies skin of axilla and the upper medial arm. The T12 nerve, subcostal nerve, arises from the ventral ramus of 12th thoracic spinal nerve, runs below the 12th rib behind the diaphragm and gives cutaneous branches to the anterior abdominal wall. Its motor innervations are transverse abdominis muscle, internal oblique, external oblique, and the rectus abdominis. The lower 5 thoracic nerves, that is T7 to T11, originate from the spinal cord, descends towards the abdominal wall, positions themselves between internal oblique and transverse abdominis muscle, have its sensory supply to the trunk and arm, and gives motor supply to the intercostal and the abdominal muscles. The prime nerve of the chest wall block is the intercostal nerve that have its origin from the anterior rami of the thoracic nerves, gives its sensory innervation via lateral cutaneous branches, and its breast innervation is from T2 to T6. Its accessibility is at the mid-axillary line. The major branches of intercostal nerve is lateral cutaneous branch, anterior cutaneous branch, and the collateral branch. In this picture, from the spinal cord arises the ventral root and the dorsal root, which joins and gives of the dorsal rami that supplies the muscles of the back, and the sympathetic chain and the ventral rami. The ventral rami continues as the intercostal nerve between the internal intercostal muscle and the innermost intercostal muscle. It gives off the lateral cutaneous branches, which again branches off into the posterior and the anterior branch. Near the sternum, the anterior cutaneous branches again branches off into the medial and the lateral cutaneous branch. This picture shows the major motor branch, that is the collateral branch, which arises at the angle of the rib and positions itself between the neurovascular bundle at the superior part of the inferior rib. This video shows the course of the intercostal nerve, as I said earlier. This gives the lateral cutaneous branch, which again branches off into the anterior and the posterior, the anterior cutaneous branch, the medial and the lateral branch. The muscular branches are the long thoracic nerve, medial pectoral nerve, lateral pectoral nerve, and the thoracodorsal nerve. The long thoracic nerve origins from C5, C6, C7. It is also known as the nerve to serratus anterior, gives its major supply to the serratus anterior muscle. The lateral pectoral nerve arising from the lateral cord gives its major innervation to the pectoralis major, and it communicates with the medial pectoral nerve via ansa pectoralis and supplies the pectoralis minor muscle. From the medial cord arises the medial pectoral nerve C8 to T1, supplies the deeper part of the pectoralis minor and the major muscle. The thoracodorsal nerve arising from the posterior cord of the brachial plexus runs along the posterior axillary wall, supplies the latissimus dorsi muscle, and it lies adjacent to the thoracodorsal artery. The supraclavicular nerves or the cutaneous branches of the cervical plexus arises from the ventral rami of C3 to C4. It supplies the lower part of the neck, shoulder region, and upper chest wall up to second rib or the upper pectoral region. Now, the chest wall can be divided into anteromedial, anterolateral, and posterior. The anteromedial chest wall extends from the sternum to the midclavicular line. It is innervated by the anterior cutaneous branches of the thoracic intercostal nerves. The innervation of anterolateral chest wall and axilla is by the lateral cutaneous branches of the thoracic intercostal nerve and the brachial plexus branches, just supraclavicular nerve, lateral pectoral nerve, medial pectoral nerve, and the long thoracic nerve, thoracodorsal nerve. The innervation of posterior chest wall. The posterior chest wall extends from the posterior axillary line to the thoracic spinous process. It is innervated by the branches of dorsal rami of thoracic spinal nerves and the posterior divisions of the lateral cutaneous branches that arises from the intercostal nerve. So before performing a block, it is mandatory for the preparation and setup of a block place. So we can have to follow strict aseptic precautions. Light source should be checked, rescue equipment ready with the presence of second anesthetist or an assistant, GA drugs and equipment ready, IV access secure, and monitors attached. It can be easily remembered with an acrostic. She looks radiant and gorgeous in mirror. This shows the essential equipment trolley. It is very essential before performing a block, especially high volume block or the deep facial block. It consists of GA drugs and the airway gadgets along with the 20% intralipid to manage the complications like local anesthetic systemic toxicity, airway compromise, and the cardiac arrest. This is the regional anesthesia procedure form. It is mandatory for the documentation and to standardize the peripheral nerve block procedures. And it ensures the patient's safety and the communication among the team. The components of this form are the patient and the procedure identification, type of the block, usage of pre-medication, and under ASA strict ASA monitors, and the procedure notes and checklist. Thank you.
Thank you, Dr. Anita. You have described very simply and very clearly. I could get a very clear picture on intercostal nerve. Thank you very much. Any questions can be taken in the last. And now I ask Dr. Mytili to speak on anterior chest wall block. Yes, you can start.
Thank you, sir. Good evening, everyone. I thank ISA Puthukkottai for giving me this opportunity. So the various blocks of the anterior chest wall are PEX 1 block, PEX 2 block, serratus anterior plane block, parasternal intercostal nerve block, and transverse thoracic plane block. So the indications for anterior chest wall block are breast surgeries, cardiac surgeries, sternal fractures, implantable cardioverter defibrillator placements, and chronic post-anatomy pain syndrome, and in all cases of trauma and respiratory distress related to COVID and SARS. So the PEX1 nerve block. The PEX1 nerve block is performed by doing a hydrodissection between the pectoral muscles, blocking the medial and lateral pectoral nerves. So the landmarks for PEX1 nerve block will be pectoralis major, pectoralis minor muscle, and the pectoral branch of the thoracoacromial artery. And the volume that would be deposited is 0.2 ml per kg of a long-acting local anesthetic. Now we'll see a schematic diagram to show the deposition of the drug. The picture depicts the hydrodissection between the pectoralis major and pectoralis minor muscle. And the landmark would be the pectoral branch of the thoracoacromial artery. And the drug is deposited between the pectoralis major and minor muscle, which is depicted as blue color. And the placement of the probe would be the patient is positioned in supine position with the arms abducted to 90 degree, and the probe is placed in the craniocaudal orientation, and the coracoid process is identified, and the distal portion of the probe is moved slightly inferiorly and laterally at the level of the second rib to visualize the pectoralis major and pectoralis minor muscle, and drug is deposited in between these two planes. So now moving on to PEX2 nerve block. Here this includes the PEX1 nerve block and also a injection between the pectoralis minor and serratus anterior muscle. Here the thoracic intercostal nerves, long thoracic nerve and the thoracodorsal nerve are getting blocked. And a schematic diagram to show the PEX2 block is the first injection is given between the pectoralis major muscle and pectoralis minor muscle, and the second injection is given between the pectoralis minor muscle and the serratus anterior muscle. This is usually performed at the level of third to fourth rib. And the probe position is the patient is placed supine with the arms abducted to 90 degree, and the probe is placed between the third and fourth rib, and the lateral portion of the inferior portion of the probe is moved laterally to visualize the pectoralis major minor muscle, and the drug is deposited between the pectoralis minor and serratus anterior muscle. So this shows a ultrasound video of the PEX1 and PEX2 block. The first injection is between the pectoralis major muscle and the minor muscle. We can see the hydrodissection between the major and minor muscles. This PEX1. And the second injection is between the pectoralis minor muscle and the serratus anterior muscle. Shows the hydrodissection of the local anesthetic. And the next block is serratus anterior plane block, where the local anesthetic is injected either superficial to the serratus anterior muscle or deep to the serratus anterior muscle. Here the lateral cutaneous branches of the intercostal nerves are getting blocked, and with the ultrasound we can do a precise needle placement and correct injection of the local anesthetic in the facial plane. The main indications are for breast surgeries and thoracotomies, and in the emergency department, whenever the patient is having any rib fractures, serratus anterior plane block is given for pain relief. The schematic diagram shows the latissimus dorsi muscle and the serratus anterior muscle, and the main landmark here is the thoracodorsal artery, which helps to delineate between the latissimus dorsi and serratus anterior. When the drug is deposited superficial to the serratus anterior muscle, it is called a superficial serratus anterior plane block. And when it is injected deep to the serratus anterior muscle between the serratus anterior and the external intercostal muscle, it is called a deep serratus anterior block. So the probe position, the patient is placed supine and the arms are abducted to 90 degree, and the probe is placed in the anterior axillary line in a craniocaudal orientation, allowing in-plane technique, and the probe is moved laterally into the axilla to visualize the serratus anterior muscle, and the drug is deposited either superficial or deep to the muscle. So this shows a video demonstrating the serratus anterior plane block, where you can see the latissimus dorsi muscle, the serratus anterior muscle, and the needle is coming in plane, and the drug is deposited between the latissimus dorsi and serratus anterior muscle. We can see the hydrodissection of the local anesthetic. Next is the parasternal intercostal nerve block. Here, the local anesthetic is deposited in the facial layer between the pectoralis major muscle and the external intercostal muscle. The anterior cutaneous branches of the 2nd to 6th intercostal nerves will be blocked by this technique, and it will cover multiple dermatomal distributions in the same site of injection, and it provides analgesia of the sternum and also the parasternal regions of the chest wall. The patient is placed supine and high frequency linear probe is used, and the transducer is placed 2 to 3 centimeters lateral to the sternal border in craniocaudal orientation, and the site of injection would be T3, T4 intercostal space between the pectoralis major and intercostal muscles. The total volume would be 10 to 15 ml of local anesthetic. So this picture shows the sonoanatomy depicting the pectoralis major muscle and the intercostal muscles. This is the pleura and this is the rib. So the drug is deposited between the pectoralis major muscle and the intercostal muscles in this space. So this is a video showing the parasternal intercostal nerve block. That is the pectoralis major muscle, and this is the intercostal muscle, external intercostal muscle. The needle is placed in plane. It reaches the space between both the muscles, and hydrodissection between the pectoralis major and external intercostal muscles is taking place. These are the ribs. This is the pleura. So we can see the hydrodissection giving a complete block of the intercostal nerves. So next one is the transverse thoracic plane block, where the local anesthetic is injected between the transverse thoracic muscle and the internal intercostal muscles. Here the anterior cutaneous branches of the T2 to T6 nerves are getting blocked, intercostal nerves are blocked. This is a schematic diagram depicting the pectoralis major muscle, the intercostal muscle. So the injection between the pectoralis major and the external intercostal muscle is the parasternal intercostal nerve block, and depositing drug between the intercostal muscles and the transverse thoracic would be the transverse thoracic plane block. The pleura is below, and the landmark is the internal thoracic artery. So to summarize, the pectoralis PEX1 block is given between the pectoralis major and the minor muscle, and the PEX2 block is given between the pectoralis minor and the serratus anterior muscle. And serratus anterior plane block, superficial block is superficial to the serratus anterior muscle, and the deep block is given below the serratus anterior muscle. And the transverse thoracic plane block is given between the pectoralis major, it is given between the external intercostal muscle and the transverse thoracic muscle. So the advantages of these newer developed anterior chest wall blocks are that they provide a effective pain management system, and it helps to reduce the opioid consumption like morphine, and the patient goes for early extubation because of an enhanced recovery, and it is a good alternative to the neuraxial blockades, and it is easier to perform with the wide used ultrasound, and it gives a targeted analgesia. It is versatile, and it has got a great potential for chronic pain management also. Thank you.
Thank you, Dr. Mytili. Your presentation is very simple, very clear. The diagrams and demonstrations are crystal clear. Thank you.
Thank you, sir.
Now I call upon Dr. Narmatha to present his topic.
So a very good evening to one and all. Once again, my sincere thanks to ISA Puthukkottai organizing team and Dr. A.L.M. sir for the kind introduction. And thank you, Dr. Selvakumar sir, for moderating this session. So let's move on to the final topic of ours today, that is the posterior chest wall blocks. So, so these are the learning objectives today. So first, coming to the posterior chest wall blocks. So until 2010, it was the epidural that was the main benchmark for the chest wall surgery analgesia. But because of the newly arising all your chest wall blocks, the epidural is getting outplaced by these blocks because they have an enhanced safety profile and technically they are easier, and it is reducing the perioperative opioids, minimal hemodynamic side effects, and it has a targeted pain relief and also early recovery and ambulation of the patients. So coming to the posterior chest wall blocks, this can be classified into either your paraneuraxial blocks. In this, we are going to see mainly about the thoracic paravertebral block. Then comes your proxy blocks. Here you have the erectospinal, retrolaminar, then your ITP or MTP blocks and the still block. And in the facial plane blocks, you have the rhomboidus intercostal subserratus plane block. So before embarking onto the chest wall blocks per se, let's move into the anatomy of the back muscle. So this is a dissection video. So this large triangular muscle, so this is your trapezius. If you remove that, you have the rhomboidus minor that is arising from the upper 1/3 of the medial aspect of the scapula, and then rhomboidus major that arises from the lower 2/3 of the scapula. And if you remove that, you have your serratus posterior superior muscle. Then comes your erectospinal group of muscles. Actually, the medial one is the spinalis, intermediate you have the longinus, and then the iliocostalis. So this extends from the cervical region and also to the lumbar and the sacral region where it becomes a aponeurosis. And then deeper to this lies your multifidus group of muscle and then your vertebral column. So first coming to the thoracic paravertebral block. So for this, you have to thank the gynecologist, Dr. Hugo Silham, because in 1905, he was the first to deposit the local anesthetic in the paravertebral space, but for a patient undergoing lobectomy for tuberculosis. Later, it was rediscovered in 1979 by Yazan and Wyatt. So before going into the block, you should know what do you mean by a paravertebral space. So if you see the video, so this is your spinous process. Then you have the lamina and the transverse process and your rib. Okay. So here you have three important ligaments here. So the ligament in between the two transverse process. So this is your intertransverse ligament. Then between the transverse process and the rib, that is your lateral costotransverse ligament. And then comes your superior costotransverse ligament. So the ligament extending from this green color ligament, extending from the posterior surface of the transverse process to the rib below. So this is the important structure of interest because to enter the paravertebral space, you have to pierce this ligament and enter the paravertebral space. So to get in detail with the boundaries of the paravertebral space, if you see the cross section of this anatomy, so this is the posterior portion, this is the anterior portion. Now you have medially the vertebral body along with the intervertebral disc. And then anteriorly, this purple color, anterolaterally, this is formed by the lungs along with the parietal and the visceral flora. Then posteriorly, as I said, this is your superior costotransverse ligament. And you see, this is continuous with your internal intercostal membrane. So that is nothing but a membranous continuation of the internal intercostal muscle. So the spinal nerve root, after emerging, it divides into the dorsal and the ventral rami, and you have your intercostal vessels and nerves, and the sympathetic chain and the rami communicants. So by depositing even a small amount of local anesthetic in this space, you can produce a beautiful sensory, somatic, and sympathetic block, thereby providing the effect similar to that of an unilateral epidural with a minimal hemodynamic side effects. And if you see, this space is not a closed door space. It is communicating cephalad with the cervical paravertebral space. Caudally, it is extending up to the level of the psoas major, that is up to the level of the L1, medially with the epidural space, and laterally with the intracostal space. So by depositing the drug here, you are able to block the adjacent dermatomes and produce a complete block. And trust me, this is the only block that can produce anesthesia for all your surgeries. All other blocks are only for the analgesia purpose. Okay. So next, coming to the indications, as Dr. Mytili told, you have all the thoracic wall surgeries. You can perform the paravertebral block for the breast surgeries, cholecystectomy and hepatectomy, where you have to give at the level of T6, T7 for the minimally invasive cardiac surgeries, for the renal and the hernia at the level of T10, L1, and your non-cardiac, non-surgical indications are your rib fracture and the herpetic neuralgia and chronic pain management. So coming to the procedure per se, so this is common for all your blocks. So the patient position, either you can do it with the patient in the supine lateral or prone posture, but I prefer to do it in the prone posture because it is very comfortable for the patient. Usually we will sedate the patient mildly with the midas and the fentanyl, put him in the prone with the pillow underneath. So this will be very comfortable for the patient as this is a deeper block and is little bit painful. Okay, so coming to the probe, you can use either the linear or the curvilinear probe depending upon where you are performing. For the thoracic level, we use the linear. For the lumbar level, we use the curvilinear probe, and depending upon the patient status. Okay, for obese patient, we have to use the curvilinear probe. Coming to the ergonomics, you see your performer's vision, the needle and the screen, everything should be in the same line. And then choosing the level. So how to choose the level? So this depends upon what is the type of surgery. Okay, so for example, if you're doing a breast surgery, you have to need to block from T2 to T6. Then you have to choose the mid-dermatomal section of the incision, for example, at the level of T4. If you are going to provide anesthesia, then you have to do it at a consequent levels or at the alternate levels. Then imaging types, you have either a transverse imaging or you can do by the paramedian oblique imaging. And we commonly use the 22 gauge 8 to 10 centimeter needle. And the drugs commonly used are your 0.25% bupivacaine or levobupivacaine or 0.375% propivacane. For a single level injection, we should not exceed the volume of about 20 to 25 ml. And for multiple level injections, you have to give aliquots of 3 to 4 ml at each alternate levels. Okay, so then coming to the approaches, as I already told, we have the transverse imaging and the paramedian oblique imaging. So why the transverse imaging? So what are the advantages? So if you see, this is very easy for the novice practitioner because the needle is coming from lateral to medial, and we can see the extended view of the pleura is seen, and also we can have a caution if the needle is directed towards the neuraxis. So how we are going to perform this transverse imaging? So that is by the sequential ultrasound imaging technique. So before that, before performing the block, you should be very confirmatory about the level you should do, because if you are doing it at the wrong level, then you will end up with a block failure. If you see the thoracic vertebra, so this is a spinous process. Actually, this is very angulated so that it lies at the level of the lamina and the transverse process of the vertebra below. So first you have to choose the appropriate level, either by counting the rib technique. So you have to place the probe in the supraclavicular fossa and then count the ribs down, or counting from below. Then only you have to perform the procedure. So we have 4 steps. First is, so this red color is the probe position. So first is you have to place the probe in the midline to identify the spinous process. Next, you have to slide the probe laterally to identify the costo-transverse junction, then slightly caudally, coming to the step 3. So identify the paravertebral space at the level of the transverse process, that is called as Shibata's window. Then you can go to the step 4, that is the articular process view. So what is the difference between the transverse and the articular process view? I will explain with the subsequent video. So first, so this is how to count the ribs. So first you have to place the probe in the supraclavicular fossa and you have to move the probe downwards. Now you can see so this is your first rib and this is the second rib and third rib, fourth rib. Like that you have to count, and which level you have to perform. You mark the level with the marker before you perform the block. Okay. Then coming to the procedure per se. So this is the first, the midline approach. First, you have to see the spinous process. Now you have to move the probe laterally. So now I am moving laterally. You can see this is your lamina. Then comes your transverse process. This is the rib. So this is the costo-transverse junction. When you visualize this, then you have to move the probe caudally. So this is your Shibata's window, that is the paravertebral space, and you have the transverse process, and this is the pleura. Later, what happened? Dr. Manoj Karmakar still modified this by using the articular process view. So what is the advantage of the articular process view? See, if you see, so just I am playing the video again. So this is the Shibata's window. You have the pleura. If you still move a little more caudally, what you can see is the articular process view. See, now the transverse process has disappeared. Now you can see this is the articular process and this is the pleura and this is your paravertebral space. So you can put the Doppler here and look for the intercostal vessel, and then you can aspirate, and if it is negative for blood, then you can inject your local anesthetic. So what is the advantage? If you see, Rather than the transverse process, the articular process is in close relation to the foramen through which your nerve root emerges. So in this Manoj Karmakar's approach, so by depositing the drug in the paravertebral space, it is very close to the nerve root, so that produces a complete block even with a very minimal volume. But in our institution, we follow the transverse process view, that is the Shibata's windows view. Okay, so then coming to the needle trajectory. So this is a patient done for a patient with a feeding jejunostomy. So the needle is coming from lateral to medial. So here, this white structure, what you are piercing, so that is the internal intercostal membrane. Okay, so after piercing this, you will find a click and then you have to inject the drug. And while injecting, you have to look for the pleura should drop down. So that is called as the pleural drop sign. So that is the end point that you have correctly injected in the paravertebral space. So can you see now the pleura is going down beautifully. So this means your drug is ideally in the paravertebral space. So here I wanted to stress one thing. So this structure, what you are piercing is the internal intercostal membrane. But I told that SCTL is an important structure of interest. Why? Because in this transverse process view, what happens? The SCTL that is in the most medial part, so that will be obscured by the transverse process view. So whatever you are piercing is your internal intercostal membrane. And while injecting, you have to give in small aliquot. You should not inject with too much pressure because a large amount of drug will enter the epidural space. That means it will spread in the transverse direction rather than in the cephalocaudal direction, and it can lead to unwanted side effects of the epidural. So then coming to the parasagittal approach. So here we have to place the probe just lateral to the scapula. First, you will see the rib. So rib can be seen as a rounded structure. Then you have to move medially until you visualize the transverse process as a squared process. And then once you reach this stage, now you slightly move the caudal end of the probe along. So that is called as the pivoting of the probe. So now I'm placing the cephalad end over the transverse process, and then you have to move the caudal end towards the rib. Okay, so this maneuver is called as pivoting. Now I can see the beautifully the superior costotransverse ligament is seen. So this is your rib. This is the transverse process. This is the SCTL ligament and the pleura and the paravertebral space. So if you see this parasagittal approach is just a progression of the erector spinae plane block, and you can advantages, you can watch easily the spread of the drug. The adjacent levels it is spreading, you can easily watch. And also the needling is, you are going to come perpendicular, so you are away from your neuraxis. So this is the video. So we have the rib transverse process and the superior costotransverse ligament. For the beginners, I would like to suggest, while coming in the out of plane technique, I will advise to use the 2OG needle with the markings or a spinal needle with a depth gauge. So why? Because, so you see in the out of plane approach, you are going to see only the tip of the needle. Your length of the needle is not visualized. So what you have to do is, first you do a scout scan, measure the distance from the skin to the paravertebral space, and you mark the distance in this 2OG needle, or you fix the depth gauge at that distance and then insert the needle, so that you will fix the safety distance and you should not go beyond that distance. So thereby you can prevent the inadvertent puncture of the pleura. Then coming to the complications. So we have a lot more of complications. Theoretically, they have compiled a lot of complications. So first thing, if you're going more medially towards the neuraxis, there is a chance that you can inject the drug intrathecally, and cephalad spread of the drug can lead to blockage of the stellate ganglion, leading to the ipsilateral Horner syndrome. And also it can block the lower components of the brachial plexus. And caudally, what happens? The subendothoracix facial spread to the retroperitoneal space can block your lumbar nerves. And also you can vascular injury and the pneumothorax. But what happens is, studied by Manoj Karmaker has shown that he has done in 1,350 patients, almost none of them had a pneumothorax, and only one had a vasovagal attack and 2 had a vascular puncture. So if you are a proponent of this technique and familiar with it, these are all just theoretical complications, okay? So you can overcome all these complications and it's very negligible. Then coming to your proxy blocks. So we have a lot of proxy blocks here. So before going into the proxy blocks, I want you to understand one of the basic anatomy. So that is called as a retroescutial space. So what do you mean by retroescutial space? That is the space behind the superior costotransverse ligament. So if you understand this anatomy, then all your proxy blocks are just a cakewalk. See, this is the ventral rami coming out of the foramen. What happens? It will pierce this SCTL, producing a slit. So that is called as a medial slit. Then again, it enters the exits and enters the intercostal space in between your SCTL ligament and the internal intercostal membrane, thereby producing a slit. So that is your lateral slit. And another, you have a space between the transverse process and the rib. So that is the costo-transverse space. So I repeat, you have 3 slits. One is between the transverse process and the rib, that is your costo-transverse space. Then between the superior costo-transverse ligament and the internal intercostal membrane, so that is the lateral slit. And then third is where the ventral rami emerges, so that is the medial slit. So you have 3 slits: medial slit, lateral slit, and the lateral costo-transverse space. So what happens whenever you are depositing a drug behind the SCTL, that is blue area is the drug. So it finds its way to the paravertebral space through these slits. Okay, so now the basic mechanism is we are standing safely behind the SCTL and we are going to produce a block that has the effect similar to that of the paravertebral block. So whenever you are depositing a drug here, you are safely behind the SCTL. You are not going to pierce the SCTL, but the drug will percolate through these slits to the paravertebral space and produces an effect just similar to your paravertebral block. So once you understand this, all your proxy blocks are just different names given to the same block. Okay. So depending upon the place where we are injecting, we are giving the different names. Coming to the first, the erector spinae plane block. So this is one of the most favorite blocks for all our postgraduates. They do it right and left in the OT for the thoracic wall surgeries. So because it is very simple and we have to just hitch the transverse process and give, it is very easy to find even with the anatomical guided landmarks. And it also has almost nil complications. Okay. So if you see the indication, starting from the cervical to the sacral, you can perform the block. For the shoulder surgeries, you can do it with a high erector spinae or a cervical erector spinae plane block at the level of C7, T1. And for the upper thoracic, you can give it at T4, T5 level. For the lower thoracic and upper abdominal level, you can give it at T7 and 8. And for the abdominal surgeries at T10 level. And even for the hip on the lower limb at the level of L3, L4, that is your lumbar erector spinae. And then for the sacral surgeries like your anoplasty or your perineal surgeries, you can give the sacral erector spinae. So you have a lot of indications for this erector spinae plane block. So this was first described by Forero et al. So in 2016, and they injected the drug between the transverse process and the erector spinae plane muscle, so that the drug spreads cephalocaudal direction, thereby blocking the dorsal rami directly, and indirectly it blocks the ventral rami by the mechanism as I said earlier. Okay, and also they found that by the Canadian Journal in 2021, if you do the block in an awake patient, when you pierce the muscle, it will this will cause the muscle to contract and a pumping action. So this pumping action causes more amount of drug to enter the paravertebral space. And also, when a patient is spontaneously breathing, because of the negative intrathoracic pressure, more amount of drug will enter the paravertebral space, thereby improving your quality of the block. So coming to the procedural prerequisites, it is the same like that of your paravertebral block, except that you can place a catheter with a erector spinae plane block. Okay, and you can, after a bolus injection, you can activate the catheter and give it as a continuous infusion, like how you do it for an epidural. So here we are doing it, mostly we do it by the parasagittal approach. The probe is placed in the just medial to the scapula. First, you will see the rib. So this is your rib with a rounded structure, and then the pleura. And the muscles you see are the first superficial is your trapezius, then comes your rhomboids, then your erector spinae, and then the intercostal muscles. Now, if you are moving medially, gradually, if you see this is getting converted, the rounded structure becomes converted into a squared appearance. So that is your transverse process. So now you can come from here, hitch the transverse process and give the drug. And also you should note that if you are doing it above the level of T6, you can see the rhomboids. If you are doing below the level of T6, rhomboidus muscle will be absent and you will see only 2 layers of muscle. One is the trapezius and is your erector spinae plane muscle. So when you are injecting the drug, so this is the end point. So this should lift up the muscle and the muscle should get separated from the periosteum of the transverse process. So this is your plane of spread of the muscle, spread of the local anesthetic. So here, one of the important complication which we miss with this parasagittal approach is the intramuscular injection. So what happens if you give the drug in this plane, sometimes it may get into the intramuscular layer and the muscle fibers may be delineated in such a way that you won't be able to differentiate whether you are in the correct plane or it is intramuscular, because the spread will be similar, like how it will look in the spread of direction in the linear direction, how it will look with the routine parasagittal approach. So to identify the intramuscular approach, you can view it in the transverse approach. So that is called as a rack approach, where if you inject the drug intramuscularly, you can see a circumferential spread of the drug. So the drug will be spreading like a circle. So that means you are in the intramuscular plane. That means you are not in the correct plane. Okay. So this is one of the advantage with the transverse approach, but mostly we go with the parasagittal approach. Then coming to your ITP or the NTP block. So this is the, both are the same, different names for the same block. So ITP is intertransverse plane block. NTP is the midpoint of the transverse process to pleura block. So this is actually an anatomical wedge between your erector spinae and the paravertebral block. So what you have to do is you have to join the two transverse process, make a line and take the pleura, that is your second line, and take the midpoint of the two. So that is your point of injection. So you see now you are injecting just behind the SETL. So what happens if you are injecting here, automatically the quality of block will be better, because you see you are depositing the drug close to the SETL. So more amount of drug will enter the paravertebral space. So the quality will be better than the erector spinae. But the thing is that you have to give it multiple dermatomal levels for a good dermatomal coverage. Okay. Then coming to the retrolaminar block. So here you have the transverse approach. In this transverse approach, like how you do it for a paravertebral, you have to place the probe in the midline and then move it laterally. You can see the lamina. Now you come from the out of plane and then hitch the lamina and give the drug in between your erector spinae and the lamina. In the parasagittal approach, so as I already told, so first initially, if you keep just lateral to the, just medial to the scapula, first you will see the rib with the rounded contour. If you move medially, you will see the transverse process. Still, if you move medially, you can see the horseshoe head appearance of the lamina. Now you come with the in-plane technique, hitch the lamina and give the drug. Then coming to the still block. So that is your subtransverse interligamentary block. So here, what we are doing is we are injecting at the base of the, hitching the base of the transverse process and giving the drug just behind the SETL ligament. Okay, so now similar to your MTP block, here also what happens, we are giving it close to the SETL. So more amount of drug will enter the paravertebral space and the quality will be better. But similar to that, you have to give it at multiple levels for a good dermatomal coverage. Then coming to the facial plane blocks. So what do you mean by a facial plane block? So here the drug is deposited between the fascia of two tight muscles so that the drug will percolate through the path of least resistance and it bathes the nerves there, thereby producing the block. Okay, so the advantages of this are, so we are depositing the drug well away from your vital structures like your spinal cord, dura and the pleura, but the amount of analgesia we are deriving is similar to that of your proxy blocks. So that is the advantage. So here we have the initially they had the rib block, that is a rhomboides intercostal block. Later they combined that with the subserratus plane, making it into a wrist block. So here there are two-stage injections are done. One is between the rhomboides muscle and the intercostal muscle. So whenever we deposit the drug here, the drug will spread medially under the erector spinae muscle and it blocks the dorsal primary. And then if we give it under the subserratus muscle, between the subserratus muscle and the rib, what happens? The drug will spread in the lateral direction and then it covers the lateral cutaneous branches of the intercostal nerve. So you can have an analgesia from T3 to T9. So the indications, you can do it for your posterolateral surgeries, your upper abdominal surgeries, for the rib fractures and ICD, scapular fracture. So you can do for the all these surgeries. So coming to the procedure. So this is the patient position. First, you have to place the probe in the transverse direction, identify the scapula and the muscles, then rotate the probe in the paramedian position, and then slide the probe caudally and inferiorly up to the level of the T9. So just I will show you the video. So this is your first probe position in the transverse orientation. You will see this is your scapula. You have the trapezius, the rhomboidus, intercostal muscle, and the pleura. Now I am moving the probe in the paramedian plane. Now what I am going to see, this is your trapezius, rhomboidus muscle, the intercostal muscle, and this is the plane, the rhomboidus intercostal plane. So here you have to inject 15 to 20 ml. Then you have to move the probe caudally and laterally up to the level of the T9 level. Now can you see the trapezius is getting ending up here. Now I move little more laterally. I can see this is the serratus anterior muscle and this is the rib. So this is the second plane you have to inject. So this is nothing but another alternative of your deep stab block, what Dr. Mytili explained. So you are giving it 2 levels. So to produce the analgesia from T3 to T9. So, so now we have completed all the blocks. Now we are into the thoracic jungle. So you have a lot of options here. So how you are going to choose your block of option for the surgeries. So for this, I want you to ask yourself on 5 questions. So depending upon the answer, you have to choose the block. So first thing is whether the block is for anesthesia or analgesia. Then what is your skill and expertise about the block? Never ever try a block for the first time for your patient. Then coming to the patient factors. Then what are the pros and cons of that block? Then finally about the surgeon's factor. So all these questions you have to answer yourself and then you decide with a block. So these are the common surgical procedures that is done in the thoracic wall. Commonly you would go for the thoracotomy, VATS, breast surgery, and the rib fracture. In the thoracotomy, that is the most painful procedure. So because it has its occurrence with the somatic, visceral, and the neuropathic pain. And if it is not well treated, it can lead to a chronic pain syndrome. So according to the prospect study of group, the ideal block for a thoracotomy is a paravertebral block. If you are not an expertise with that, you go with the erecta spinae plain block. Then coming to the VATS, according to the prospect, actually epidural is contraindicated and you can go for the paravertebral or the erecta spinae and even the deep stab block. Then coming to the breast surgery, so this is not a simple surgery. You have a lot of options. Either you can patient come for a lumpectomy, mastectomy, axillary node dissection, or it can be a reduction mammoplasty or a submuscular augmentation. So your procedure cannot be the same for all. So if you see the breast innervation, you have actually 3 innervations. One is the cutaneous and the subcutaneous innervation, that is by the intercostal nerve. And you have the muscular innervation from the brachial plexus and your dermatomal from the superficial cervical plexus. So a single block per se cannot be helpful in a breast surgery. So you have to give a combination of blocks. You can combine your paravertebral block with the PEC2 or the deep stab block. And if you are doing the surgery in the medialmost aspect of the chest, you can go with the paravertebral with a PIFB block. Okay, so this is the combination of blocks: paravertebral with the PEC2 or SAP, or paravertebral with the PIFB if it is a most medial part of the chest. Then coming to the rib fracture. So for the sternal fractures, you can do with the bilateral PIFB or the transverse thoracic plain block for the pain relief. And in case of the anterolateral fracture of the rib, if the patient was able to sit up, then you can do the erecta spinae or the paravertebral plain block. If the patient cannot roll down and the patient is supine, you can go with the PEC2 or the deep stab block. Similarly, in the posterior rib fractures, you go for the erecta spinae or the paravertebral. And in the posterolateral, either the deep stab block or your erecta spinae plain block. If it is a bilateral, then you go for your bilateral erecta spinae, bilateral stab, or your epidural. So these are the for the various rib fractures, our various analgesic managements. Then coming to the complications, you have the vascular puncture, hematoma, pneumothorax, and the most important is the last. So don't exceed the safe limit of the local anesthetic because all these chest wall blocks are high volume blocks. So always use the adrenaline mixture so that it will reduce the systemic absorption of the local anesthetic. And at the same time, you have to monitor at least for a minimum of 14 minutes. So that is the peak time when the drug action will come. And also you keep the last rescue kit available with you. And coming to the contraindications. So apart from your regular contraindications like patient refusal, local anesthetic, allergy, infections, Coagulopathy, when the patient is on anticoagulants or antithrombotic drugs, according to the European study of guidelines, they said that this thoracic paravertebral block, which is a deeper block, that is contraindicated. All other blocks can be given even if the patient is on antithrombotic drugs. So with this, we have seen all our facial plane blocks, our proxy blocks, paravertebral blocks, and thank you for the patient listening. Thank you, sir.
Thank you, Dr. Narmatha. You explained very clearly and demonstrated the paravertebral block. That means you are doing it regularly, it seems. Otherwise, you could not have described such a clear message. About the proxy block, anyone listening for the first time, it will be really confusing. There are so many names, MTP, STIL, CTF, MIC. There are different names. They all focus on a small area, but we expect the drug to reach the paravertebral space and the vertebral foramen to produce its effect. But it's difficult to memorize all these names. So realizing this, the experts from European and Asian Society of Regional Anesthesia, they did a consensus study. Nearing over almost 50 experts across the world, they meet for 3 times, after 3 rounds of talk, 2 electronic meeting and 1 round table meeting. They formulated a consensus and to how the block should be named, because it's everyone is coming out with new blocks with the different names focusing on the same area. Different blocks are given a same name and same place is given different names. So to avoid this, they have formed a consensus. It's published in Anesthesia Analgesia Journal. For example, many of the names will be changed soon. The pectoral 1 block, it is given between pectoral major and minor. So it's given a name interpectoral block. And another one is pecto, pectoris minor and serratus anterior, it's given pectoserratus block. Similarly, these all proxy blocks, MTP, STIL, CTF, MIC, they are all given a single name, intertransverse block. It will be less confusing, and for people reading and teaching also, it's easier. Recently, I published an article in IJA about intercostobrachial nerve, which is very effective. And when I submitted the paper initially, I given the name intercostobrachial nerve blockade. Then I was asked to change the heading, the name of the block. It should be according to Delphi Consensus Guide, as published in Anesthesia Analgesia Journal. So I changed to subpectoral intercostal plane block. Then it is accepted and published. You can go through the study. It will be very useful. So it will give a better understanding. Thank you, madam. Very good.
Thank you, sir. Thank you, sir.
There is a question, moderator, sir. There is a question.
Yes. Muthukumar, Dr. Muthukumar Rajagopalan, how successful if these blocks, posterior blocks, given with landmark guidance? Can we use nerve stimulator? Question to Dr. Narmatha.
Sir, landmark guided, actually previously in the olden days, we are doing the paravertebral with the landmark guided technique only, sir. Yes, so just we have to go teach the transverse process and walk over, and once we get a loss of resistance, we will inject the drug. But nowadays, because according to the legal issues and the ASA guidelines, we are doing with the ultrasound guided. Even your erector spinae also, we can do it with the landmark guided technique. Just you have to go just 3 centimeters lateral to the spinous process, and then you have to hitch the transverse process and inject the drug. But the thing is that whether you have injected in the correct plane, so that will be well taken up when you are seeing with your eyes in the ultrasound. So that is why recently we have to go with the ultrasound guided. So because most of the hospitals we are having the ultrasound guided, so we go with the ultrasound.
It is safe also.
Yeah, it is safe for the patient, and legally also we can say that we were in the correct plane.
What about the use of nerve stimulator? The same question. Can we use nerve stimulator?
Yeah, nerve stimulator also we can use that, but one thing we can combine ultrasound with the nerve stimulator. So because whenever you are using the nerve stimulator, actually it doesn't give a complete conclude like how you do it for the brachial plexus. Whenever going through the muscles, it can produce muscle contractions. With all your posterior thorax muscles, the contractions can come. So once you teach the transverse process and your contracts, you should not get any muscle contractions when you reach the transverse process, then you can inject the drug. Actually, whenever we are targeting a particular nerve, then you can use a nerve stimulator. That will be useful. For all these facial plane blocks, I think nerve stimulator is not that much useful.
Thank you. What is the experience with the paravertebral blocks, madam? Are you practicing regularly, and what type of cases you are doing, and how is it useful, successful, and about complications?
Sir, actually, yes, sir. We are in our Coimbatore Medical College. We are doing paravertebral block mainly, especially if the patient is very frail patient. For the emergency cases, if they are coming like for a feeding jejunostomy and for the breast surgeries, for that and all, we do it with the paravertebral. So with the anesthesia purpose. So we do it feeding jejunostomy by blocking the paravertebral, all the from T6 to T10 we block, and then instead of the GA we give the paravertebral and we do the surgeries. And for the breast surgery,
how successful it is, madam? Are you implementing with any other vitamin or something, or doing it in a single place or multiple places?
Yeah, for the anesthesia, we do it with all consequent levels, sir. We give 3 ml in every floor, whatever the segment we need to block. For example, from T6 to T10 means we have to give 3 ml at each level. For the analgesia, for a breast surgery and all, we give it at the mid-dermatomal level so that we will get an analgesic effect only. But thing is that in a case of sir, in a case if the patient is a very hemodynamically unstable or so those kind of patients, you have to be very careful because these paravertebral blocks can produce hypotension. So that thing you should be very careful when you are doing it for the if the patient is unstable or if the patient is already taken up with emergency with already hypotension. So that and all you should be very careful while giving the block.
What is your experience for breast surgery, CA breast surgeries?
Sir,
sole anesthetic, sole anesthetic.
So definitely sole anesthetic, we do it not for all the surgeries, sir. Only for if it is a lumpectomy or your fibroadenoma like that. So for if there is a extensive dissection, like they are going for a flap, LD flap and all, or if the axillary node dissection, MRM and all, mostly we combine it with the GE. So yeah, here with it.
Thank you. Thank you. Excellent presentation.
Sir, moderator, sir, I will ask one clarification from you. If your block is performed with ultrasound guidance,
yes,
either upper limb or lower limb, chest wall, can you be so sure that it will be effective 100%? Or the even ultrasound guided nerve blocks may fail because landmark technique we have seen failure. Then this nerve stimulator guided techniques we have seen failure. So what about this?
In my experience, upper limb and lower block, it nothing. It will be 100%, more than 99%. I can say. No technique will be 100%. You can have.
Then what do you think may be the reason?
Failure? Yes, sir.
No, I have seen many developed centers. They perform brachial plexus block, then they come down and perform axillary, then they come down.
No, sir. No.
Because they say one nerve missed, another nerve missed. So
no.
What will be the reason behind that? Because we are seeing the anatomy, we are depositing exactly, we are seeing that hydrodissection, the reasons, everything is seen. Even then, it is not acting.
Failure means you are not injecting the drug closer to the nerve.
No, I am asking.
You are not giving
no, even that is what I am saying. Even developed centers in Tamil Nadu, I have seen. They are blocking. It is visualized. They are showing the muscle fiber by fiber, nerve fiber by fiber. Even then, there is so. It is $1 million question. Why it fails? They are checking the trained operators, experienced operators. They do, but even then, but anyway, the failure rate has come down than this landmark technique, and the lower the quantity of local anesthetics have come down very much drastically. Because we used to give, when we were PG, we used to inject 40 ml for brachial.
Now I restricted to 20 ml. Very good percentage.
They are using 12 ml only. Many people are using only 12 ml. So they have come down.
That may be the reason. When you use lower volume, the effect may not be there in all cases. Sometimes you may get failure. That's I am satisfied with 20 ml without any complication. And previously, we were doing with 40 ml in all cases. Without any complication. Unless you injected into the vein, you are not going to get the last. So you are restricted to 20 ml. So 20 ml is a good thing. You will get adequate pain relief for surgical anesthesia.
Thank you. If there are no other remarks, we can go for a formal vote of thanks by Dr. Hema, our treasurer.
Okay, thank you, sir. Good evening, everyone. I thank all the participants in today's episode on ultrasound guided regional anesthesia on chest wall blocks. I thank our academic chairman, Dr. A.L.M. sir, for guiding us throughout the series. I thank Dr. Amita, postgraduate, Coimbatore Medical College, on the topic on innovation on chest wall block. I thank Dr. Mytili, senior assistant professor, Coimbatore Medical College, anterior chest wall blocks. You have given us a clear and easy to understand presentation, ma'am. Thank you. I thank Dr. Narmatha Yangtse, Associate Professor, Coimbatore Medical College, on posterior chest wall blocks. Ma'am, you never fail to impress us. Thank you. I thank our moderator, Dr. A. Selvakumar sir, Chief Anesthesiologist, Thiraviam Orthopedic Hospital, Nagarkoil. Thank you, sir. Thank you for your cooperation, sir. Thank